About cervical spondylosis. Cervical spondylosis is an age-related degeneration of the intervertebral discs, LUSCA joints, and intervertebral joints of the cervical spine that results in narrowing of the spinal canal and intervertebral foramen. It is called cervical spondylotic myelopathy when it causes spinal cord symptoms, and cervical spondylotic radiculopathy when it causes nerve root disease. Cervical spondylotic myelopathy and cervical radiculopathy are the two most common forms of radiculopathy. Symptoms. In cervical spondylosis, patients often complain of neck pain, stiff shoulders, upper extremity pain, numbness, sensory dullness, dyskinesia, and gait disturbance. Pain is strong upon waking, eases during the day with warmth, and often increases in the evening with muscle fatigue. Physical examination. The first step is to check the neck posture, i.e., the presence or absence of neck drop syndrome or strabismus. Check for limited range of motion, tenderness at C2 or other sites, or tapping pain, and check for neurological findings. Jackson test. The Jackson test is a test for nerve root irritation symptoms. The Jackson test is a test for nerve root irritation symptoms when the cervical vertebrae are slightly bent backward and the head is compressed downward. Radiating pain occurs in the upper branch of the affected side. Spiraling test. The spiraling test is a test for nerve root irritation symptoms when the cervical vertebrae are flexed posteriorly to the affected side and axial pressure is applied. The intervertebral foramen is narrowed and pain is felt in the upper branch of the affected side. L'Hermite sign. L'Hermite sign is seen in the supine position with the head flexed forward in a dynamic manner. L'Hermite sign is positive when the patient experiences electric shock pain from the back to the lower extremities. 10-second test. The 10-second test is a test for the presence or absence of fine motor deficits. The number of repetitions of GU and PAR in 10 seconds is counted. 20 repetitions or less is considered to be dyskinesia. Adson test. The Adson test is a test to determine the compression of the subclavian artery. Muscle strength test. A simple screening procedure is as follows. The first step is to check the strength of the muscles around the shoulder and the range of motion of the shoulder joint by performing the bonsai movement. Next, check the muscle strength of C5 and C7 by bending and extending the elbow under resistance. Dorsiflexion of the wrist to check the muscle strength of C6. Then measure the grip strength with a grip strength meter. Inspection. Radiography, CT, MRI, and myelography are the most common imaging tests. If neurological symptoms are present, MRI should be performed promptly. In case of pain only, MRI should be done as needed. Cervical spine radiography. Note the alignment, bone status, fractures, osteoporosis, bone atrophy, bone destruction, osteosclerosis, osteoporosis, osteolytic changes, etc. Narrowing of the spinal canal, narrowing of the intervertebral discs, changes in ligamentous attachments, and soft tissue swelling. In the frontal view, the spinal alignment and the shape of the Ruschka joint should be noted. In the normal state, an oblique articular cleft is seen on the outer side of the vertebral body, and in the deformed state, osteophytes extending laterally from the limb of the Ruschka joint appear. In the lateral view, the presence or absence of spinal alignment, osteosclerosis of the vertebral body endplates, osteophytes at the anterior or posterior vertebral body margins, anteroposterior diameter of the spinal canal, height of the intervertebral disc space, ossification of the anterior and posterior longitudinal ligaments, and changes in the width of the retropharyngeal and posterior tracheal cavities are checked. As for spinal alignment, since the cervical spine is physiologically curved forward, check for loss of physiological forward curvature, S-shaped deformity, and slippage. The anterior-posterior diameter of the spinal canal is an index of the width of the spinal canal, and the normal value is 14 mm or more. Changes in the width of the retropharyngeal space and posterior tracheal space are caused by abscess formation in the anterior cervical vertebrae or hematoma and edema due to trauma. The anterior-posterior flexi on lateral view mainly evaluates the stability of the cervical spine. The interatrial distance between the annulus teeth is enlarged in the forward flexion position when rheumatoid arthritis or trauma causes subluxation of the annulus. The normal distance is less than 3 mm. In the presence of instability, the posterior inferior margin of the superior vertebral body and the anterior superior margin of the inferior vertebral arch are measured during anterior-posterior flexion, and if the measurement is less than 12 mm, it is considered dynamic stenosis. The bilateral oblique image confirms the narrowing of the intervertebral foramen, and the aperture frontal image is taken at the time of dental process fracture or fixation of the annulus rotundus. Treatment: medications, injections, orthotics, physiotherapy, nerve blocks, and surgery are known to be used. Drug therapy, anti-inflammatory analgesics, muscle relaxants, and gastritis medications are often administered. Poultices may be used if the pain is weak. Injection therapy, if the site of pain is obvious. Trigger point injections should be given. Saline 100 ml plus neurotropin registered sign. 1A plus methicable registered sign. 1A or decadron registered sign. 2-4 mg if pain is severe. Orthotic therapy, if the neck cannot be moved due to pain, use a cervical collar to rest the cervical spine. Physical therapy. Physical therapy is not performed in the acute phase, but after a week or so and when symptoms subside. Cervical traction, hyperthermia, and stretching are used. Surgery. Posterior cervical spine surgery is known as single-door spinal canal expansion for cervical spondylotic myelopathy. Anterior cervical surgery is known as anterior decompression and fusion for cervical disc herniation.